We really encourage the ACPs in Sheffield to have a broad range of supervisors, because actually it's about finding the right person for that particular element of the role. So it may be that they work with a senior nurse or a senior other allied health professional to do some of the leadership or management roles. So they may work with a line manager, they may work with a nurse director, or they may work with their professional lead within their own profession. Or it may be that they work with our research team to develop and research and audit tools. So it's about finding the right supervisor for the right role and playing to people's strengths, really.
You can't just take a medical model of supervision or a nursing model of supervision and just lift it into the ACP workforce. The way that we do that within the trust I work is that all ACPs will have a clinical supervisor. The clinical supervisor would generally have expertise mainly around the specialty clinical competency set, as well as the generic clinical competencies. And they'll provide supervision, which will either be formal, direct sign-off, or they'll also have access to clinical competency supervision on the shop floor as well. And then there's a consideration of the other three pillars of practice, which we do by giving our ACPs access to supervisory groups across the pillars of practice, but also ensuring that through our apprenticeship that we're accessing the supervisors within the universities as well.
Within the context of where I work, it's obviously musculoskeletal physiotherapy. However, that we're not completely isolated within that. I work with a sports and exercise medicine consultant. We work with pain management consultants. We work very closely with the secondary care rheumatology team. And also we're referring to the orthopaedic team and neurosurgery and all these other different areas. So we can draw on those other professionals to support us with our supervision. And we should, in order to make sure that, pathways are fit for purpose and that the patient journey is as streamlined and efficient as it possibly can be. And I think the framework document really does highlight that. It focuses on the fact that we need to work in a multi-professional way, and particularly with healthcare becoming ever more complex and the lines between professionals becoming quite blurred in some instances, it's never been more important to adopt those methods of working. Obviously, I think the key thing is that it should be bespoke. It has to be unique to the individual. There cannot be a one-size-fits-all on this, because everybody has come from a different background. They're at different levels of practice and experience. So it must be tailored to the individual.
What we've been doing at St George's Trust is we've been mapping across the trust, looking at anybody who is working in an advanced practice role and mapping them against the framework of advanced clinical practice. And also as part of that, we've been looking at their supervision arrangements, which have been really varied across the trust. Doing the mapping exercise has really helped to bring out some gaps. So for example, I've been meeting up with some of the practitioners who work on the hospital at night team, and obviously most of the time they're working out of hours, so having supervision for them has been very challenging, but they've been working through it with me and now have identified some coordinating educational supervisors who are going to be the consultants who lead that team, as well as having some associate supervisors who they will be working clinically, for example, some of the registrars that they're working on a day-to-day basis. So this has really helped to try to make people really think about their supervision arrangements.
Allocating people to different departments within the trust is very helpful. So for example, trainees will spend time in the emergency department, in critical care, in the acute medical unit, in the general surgical department, in the orthopaedic department. And I think the primary supervisor, the educational supervisor, if you will, for each individual has to, tap their network of friends and colleagues to make this happen.
In primary care, certainly our primary care training hubs are a big part of the world now for delivering education. Working across with the CCGs, looking at pathways, there are lots and lots of opportunities, and we have to think differently if we're able to operationalise this in the best way possible.
it's impossible to discuss everything. So having very clear agenda items about what they'll be discussing, it might be a practice issue, it might be something to do with research. So making sure that they're well prepared for the supervision and actually can map back onto that initial contract to say, these are the things that we agreed to discuss. We might be discussing this particular aspect in this setting. However, we haven't forgotten the rest of that. And then at the end of each supervision session, being very clear about what's been discussed and what those actions are. I think people don't probably give enough importance on reflecting back on that discussion. So being able to say, okay, these are the things that we talked about, this is the action. It gives meaning to the supervision arrangement, because what you don't want is to always have discussions but actually don't see any product to those discussions. I think also having very clear escalation processes. So absolutely you cannot match can't always match people. There might be conflicts of interest, there might be issues in terms of how that person perceives they're being treated. So I think within that governance structure around supervision, there needs to be a clear a sort of process whereby if the supervisor and the supervisee are having challenges, what is the next step? Whether that's around mediation, whether that's about engaging an associate supervisor to sort of help in a three-way sort of discussion, there needs to be a very clear process as to how they will come out of that difficult, challenging period.
The people that you have are your key resources, so look to them, look for the resources that you have and what they can offer, what they can bring to support supervision. The other thing is making sure that there is ring-fenced time. And this is the costly bit. We're taking time out of clinical work potentially or other things, but it's so important, and it demonstrates that the employer is doing their bit, and also recognises the importance of it, which again filters down to the clinicians, understanding that this is a really important and key part of their working practice.